Hello, and welcome to the Journey of Grief, Becoming Us Without Them. I'm Barbara Field, a licensed marriage and family therapist. I specialize in the treatment of addiction and trauma and attachment and grief. And I started this channel so that there would be a place for resources for people grieving, whether you're someone who's going through grief or someone who treats people in grief. Everyone's life is affected by grief, and there's no wrong way to do grief. So the goal is to just put stuff up there that normalizes the experience for everyone. And today I've asked Alya Ahmad to talk to us about grief. And so how about if you introduce yourself and tell us what you'd like us to know?
Well, thank you, Barbara, for having me on this podcast. And I think it's an important topic, and I'm very excited to talk to you about that. I am a physician. I am and CEO of Shaw Minds Healing Center. It is a center that mental health treatment center, essentially. We do ketamine assisted therapy. We do therapy. We do integrative medicine. And we also do personalized medicine in a way that really focuses on what is truly wrong with somebody when they come in, essentially, really looking at root cause medicine is how I describe it. And we have several modalities of work that we do with ketamine treatments, with therapy, and even doing TMS, which is transcranial magnetic stimulation. And often we combine all these tools, ketamine being one, TMS being another, therapy being another, and integrative medicine being another, to really get to that root cause treatment of what is really manifesting in the body as anxiety, depression, all those symptoms. And those are just symptoms. So really get to the root of what is triggering that. Grief is an important component to a lot of the work that we do. And as you said, grief is, everyone is affected by grief, whether it be the grief of their lost loved ones, or their dog or their pet, or their life story or their identity. And so we see grief in many forms and fashion, and there's quite a diversity, I would say, of grief that exists in people's life and story. I myself am trained in narrative medicine as well. So I did my master's training in Columbia University in narrative medicine. Really, for me, when I started to look into things that I was grieving through, which really started when my father passed away and I was in my residency. And I had a very difficult time during those years. I didn't even realize I was clinically depressed until later, but I worked through that grief during that time, which really brought everything up to question. Like, who am I? Why am I doing this? What has happened? I've lost my father. I lost a key component of my identity as well as my history. And it was a very tragic death as well. And also I'm an immigrant and have lived in many, many different situations and countries. And as a family, as immigrants, we often grieved our migration. And that was our grief story that we really carried from one country to another. Like, why are we here? And what brought me to the United States was also in my history as a young child and grieving who I was as a person. Where do I come from? Like, where do I belong? And always felt like an imposter in every country, in every situation, but was quite resilient and lived through that, worked hard as an immigrant and worked hard as a human, became a doctor only because I enjoyed school and enjoyed learning and found that the human connection was really my calling. But during the time that I was in my residency was a critical stage of my life, essentially because there were so many stories, there were so many patient interactions that I was grieving through while working as a doctor. And it was in that month where I had to travel overseas to see my father in a very critically ill situation. I was 28 weeks pregnant when I traveled to see him, and I was in my third year of residency. And in that month alone, I was in the ICU and had witnessed 17 children die. And there was no space at that time in my life to really talk about those things, those stories, those conditions, those situations. And I came back. My father passed away, and I worked continuously, continued to, fight through that condition that I was experiencing in a very functional manner. I was functional. I took care of my children. I had 2 children by then. I had a premature baby after my father's death, and I was in the ICU during the same rotation, during the same time frame. And there was a grief that I felt of losing my baby's, timeline, like, not even being able to consent to his birth because I was I was so sick. So as you can see, all of these things kind of coalesced in that peak moment of my life. Years later, I decided to write about these things. And I always was a writer. I always liked to journal. I would document sometimes the stories that I worked through in terms of the clinical cases. And it was one day when I was talking to another doctor, and he asked me, "Why do you do pediatrics?" And I said, "Well, I love children, and it's such a fun environment to be in, and children are great, and they really get better, and you really can do so much, and there's so much potential there." And he said, "But I didn't like pediatrics because it was so hard. When you see children get sick and ill, I used to feel really sad." And I said, "Really?" I kind of went, "Really? That happens?" And he said, "Well," and I said, "No, but it's still such a happy environment." And he goes, "Well, that's the problem, because I was feeling so much, but I couldn't pretend to be happy." And I said, "Well," and I thought, was I pretending to be happy while I was going through all these things and being a really good doctor and taking care of children and taking care of their families and always upbeat and always, doing things in a way that was engaging and loving. Um, and then I thought back and I said, well, um, how do I process this? What's my way of processing? And then I realized, well, you write these stories, you write down these things as a way of kind of uh, offloading or downloading those experiences. And I realized it then. So then I became very curious about writing. So I applied to the program in Columbia, the narrative medicine program, thinking I was going to be a better writer and it would teach me how to write. Uh, but that was not the case. In fact, narrative medicine is really the use of the creative, the literary, the science behind the art of medicine, using visuals, using music, using the arts, and in really enlisting that as a tool to help doctors, to help understand illness, to really see and apply these tools to really enhance the benefit of certain conditions. And there's a whole science in this, and there's a methodology of teaching this to others. And so I became fascinated by how this could work, and started to bring this into my teaching as a professor and teaching residents and students and teaching the art of empathy and teaching the art of, and what are the creative ways that we can do that and bring that back into medicine. And it was a lot of fun. So writing was one component of that, but using poetry and prose and the visual arts and really engaging with the story of illness, like what is the person and the context of their condition and who are they and how do we apply these creative tools to really bring in the understanding of what really is maybe happening. But it was also a way for me to really work through my grief, my history, my generational trauma, my migrations across continents, my way of seeing myself and working through a lot of loss, a lot of loss of, again, identity, a loss of, but a discovery as well. And that is the beauty of this work. When you're doing grief work, you really get to the painful place. And I've seen this over and over again with patients that in the hospital setting, because I'm a hospitalist. So when you see patients in the hospital, they're especially pediatric patients, you're really seeing the very critically ill, and you're seeing the family, and you're seeing the child, and you're seeing the parents in their worst state, their most feared state of being in a place that they don't want to be in, of course, and having to deal with things that they're really just truly not really able to process at the time that it's happening. And you're observing this. And so I really felt that my way of processing was that. So how does then grief work when we do work with patients? So, and as I said, there's this process of discovery. There's this process of being in that most painful moment with patients and families and children, and being able to allow that space for them to really feel safe to share their fears and concerns in the most supportive way. And of course, with narrative medicine, you get the extra tools. You get the unique kind of way of working with that, and you can be so creative. And that's what I enjoy uh, about this, the work that I was able to really implement in the hospital setting. And I know that's a long answer to your question, and it kind of also brings me back into, well, why am I doing what I'm doing right now at Shawn Minds?
Yeah, so just one quick little transition. So, being someone who really, really, really has experienced loss and really gets lost, not just out of a book or out of class, but from the deep, many ways in which you have had to walk through grief, how do you think that affects you as a person who is a doctor?
Yeah. In medicine, we're often told, don't feel, don't cry, don't try not to feel too much for your patients. And that itself is a barrier in my view, because you do feel, you know, it's not like you don't feel. You're not a robot. You're a human being. And I've had times where I've cried and I've held back my tears as well, and had to struggle with that process, because um, as a doctor, you do have to do that work. And I see this now in mental health, especially I'm working among therapists, that you have to do your own work to really be able to maintain that level of, and compassion, because fatigue does happen, right? And this is where I see in medicine, where people who are really chronically in situations where they become numb to their environment, they become numb to the patient's experience and to their own experience as well. And so that disassociation, what we see in trauma, is also happening not only in that situation, but also with the doctor themselves. And that's why doctors should be doing their work just as therapists and other mental health providers do their work to take care of themselves. And that's how I see it kind of showing up. That you have to have that check-in often with yourself.
And so, what do you see when a doctor has very methodically not done their work?
You see them as disconnected from the story of the illness. They become very oriented on checklist medicine, is what I call it. Is something wrong with you? If something's not wrong with you, well, you're not, there's nothing wrong with you. The labs are okay, the things are okay. They don't really become, they're not curious, they're not really digging in. they're not asking beyond what they see. And if it's not in, visibly apparent, or it doesn't follow the books, or the, what the books say about how things present, they're not interested, or they become kind of disconnected from that, I would say, the patient's experience, or and they don't try to really engage at that level. And I see this a lot also in more so now, as we're treating depression, but what are we really treating? And so depression is just a symptom of something else. And is depression caused by the person who has gut issues and chronic pain, and so I see doctors asking, well, if you're depressed and here's a prescription, and call me in 2 weeks. And so there's that, I say checklist, but also this method, and you get taught this method in this differential, and just if it doesn't fit the box, well, it's not that. Or
Yeah.
if it doesn't fit if it's not a, and in mental health, this really, really happens a lot more, because people are assigned a label, but they're not a label. And so and if they're not that label, and they don't follow that, they're not responding to that algorithm of treatment, well, I have nothing else I can do for you. And there's a sign off, and there's a go to this doctor, and or the patients are kind of sent around, and there's no ownership of really digging into what else it could be.
So tell us about your transition. So what you're doing now is substantially different from what you were doing before. So how did you get here from there?
Well, I don't see it as substantially different. I just see like the lens is in a different angle. I see the work that I do now, as I said before, not just focusing on the symptom, but really looking at what brought up that symptom, and where did that symptom really begin. If it has to be grief, well, what are you grieving? Is it the loss of somebody, or the loss of something, or the loss of that connection, or that loss of that experience? There's more to grief. There's more to that condition than what meets the eye. So I think that's kind of my approach. And that was kind of my approach even before. I felt very disheartened, especially during COVID, when things started to change, and you were even more disconnected from your patients with the mask and the gowns. And I was in the hospital at the same time. And I witnessed this right up very, right in my face, where there was the barrier of even making contact with the patient. And that itself was traumatic for me, as well as for the patients. I could see that. Patients coming in the emergency room, and you wouldn't even go into the room, and because there was so much fear around a condition that was just pandemonium, right? There was a lot of fear of even having that contact. And then there was the barriers of your mask. There was the barriers of that human connection. And we became even more disparate, and conditions even became worse, because of that loss of that human contact and that human connection. Conditions even worsened. A heart attack would present 5 days later versus earlier, because there was so much fear about going to the hospital. So it just made the work even harder to provide. And then you were given this timeline of seeing a patient, because insurance, you have to be productive, right? As a doctor, it's always like your productivity is measured by the hospital system. If you're not seeing 20 patients, 4 patients an hour, there's a measurement. And that became very frustrating. And so then I had to leave hospital medicine. I'm still a hospitalist, and I still work part-time. And I had to go through my own work at that time, and started to really, had my first psychedelic medicine experience, and that opened the door to my own grief and history of my own trauma. And I saw it and I felt it, and I could, I had kind of subdued it. I had like encased it. And my own, I mean, I've told this to my staff, like, I think I've had every kind of trauma that there has been, meaning physical abuse, emotional abuse, neglect, sexual abuse. I mean, generational trauma carried from our lineage as immigrants from my mother's generational trauma, and her, I mean, the history of our losing our family and losing our, our lineage, and as I talk about it, I can even feel that. And there's so much to it that sometimes it feels like, well, how am I even alive? And um, so I think as a physician, I feel like I do have some extra tools under my belt because I can relate in a lot of ways to the stories I hear and to the experience that patients present with. And that has kept me grounded as a physician, as a human being. And I believe now more and more that medicine is not about the prescription or the procedure. It's really about the connection you have. And I call it like that connection with the patient, but also in that third space, and what's learned in that third space between the patient and the provider. Like there's a richness of that shared story and that shared um, and being able to witness it just as much as you try to treat it, right? To be a witness to something so patients can allow themselves to be really felt, heard, seen, and understood. And I think that's where the healing really is.
Yeah, the research is all over that sense of connection. Just one really simple little research when patients come in with just a cold and the doctor is empathetic and warm and engages with them and says stuff like, wow, isn't it terrible getting a summer cold? I just hate it when that happens. Versus someone who comes in and very professionally and very kindly and very methodically checks off the symptoms, gives the recommendations. The people who were just seen and heard and related to recover 3 to 5 days sooner than the people who are very professionally taken care of.
Yeah, yeah, there is a difference. Um, and I think that's the power of healing, as just provided and highlighted towards, because it's really that shared storytelling, right? Somebody gets to witness what I'm feeling and what I'm thinking and what I'm fearing. And that
Yep.
is, and this happens in grief work as well. When people are grieving, they've lost their father and mother or friend, and they get a space to just be, whether they want to cry or whether they want to just talk about it or whether they want to just experience or be in contact with that grief. Because there's so many things that your body does, right? When you are grieving, sometimes it doesn't even allow you to grieve. It says, no, you cannot grieve. I'm going to block that grief place from your body and keep you working and functional. Um, and it, so there's, but it's doing that as a protection. And
Right.
when we do ketamine treatments, we see that unfolding and that contact with that emotional space that patients often get to, um, when the default system is tuned down, when their pattern behavior becomes a little looser and they're able to make contact with that emotional state that they may be encasing, like I did.
So tell us about ketamine treatment. A lot of people have, thinking of the old days and LSD and
Yeah.
wild ramblings.
Yeah.
And so what can someone expect when they come into your office and say, hey, my friend did ketamine. I would like to do ketamine.
Yeah, there's a lot to it. And I think ketamine is a legal medicine for treatment-resistant depressions, especially when it's trauma-related. And treatment-resistant meaning when every other medicine hasn't worked, it can be an indication for treatment. But I say that it's not necessarily because that you're resistant, and there's a lot of blame on the patient that you are resistant, so that's why the medicine's not working. But really it's just it's another operating system to work with, another neuroreceptor, another process, another receptor site in the body, in the brain, that where ketamine works. So it is a legal medicine, a legal psychedelic, I would say. And it works on particularly the GABAergic system, especially in areas of trauma. And it's an antidepressant. In low doses, than anesthetic doses, it works as an antidepressant, and it has a robust antidepressant effect. So it helps patients to lift their mood. And it has, it's also an anti-anxiety medicine, so they don't feel bothered by their symptoms. They're not reacting or responding to their symptoms. When you apply therapy with ketamine, patients are able to really let go of, again, those protector parts that are blocking them from their emotional state or their trauma, and as when you do therapy, especially with patients who have been carrying grief for such a long time or depression for such a long time, it allows them to really process that experience in a very safe, supported way, both physically safe, right? And also the body doesn't respond to that trauma in the same way. So they have a psychedelic experience, meaning a meditative experience while they may be thinking about, oh, this horrible event, but their body and mind isn't responding to it in that way that they would if they weren't in that type of setting or experience. And so it helps patients to process.
They can see the story and understand the story without all of that trauma response in their body.
Exactly. Yeah. And revisit it in a way, like I said, with therapy really allows them to see it in a different way, or change that, or work through sometimes their what breakage, I call it, kind of reassociating to the dissociated part, because ketamine is a dissociative anesthetic. It does create this kind of mind-body disconnection for a brief period of time. But that's exactly what happens in trauma, right? There's a dissociation from that experience, and your body or mind responds to it in a certain way. So we use it as a reassociating to wherever that dissociation occurs, and kind of revisiting it and working through, and because trauma isn't what, as Gabor Mate says, it's not what happens, it's what happened to you, what happened in your body at the time. And it's a normal response to an abnormal event that response then becomes abnormal to normal responses later on.
Right. So what might you see? Describe a little bit more about ketamine treatment, because someone comes in, what happens first appointment, what happens next,
Oh,
what
sure.
happens next, what happens next?
Well, ketamine in our center, we take an integrative approach. As I said earlier, we do medical history, we do a medical intake. And because I'm trained in narrative medicine and integrative medicine, and I believe in the sciences of holistic medicine as well, the functional health, we really try to get a very comprehensive history of what's the condition, what's the medical condition, is there any other concerning conditions that are there, and try to rule those things out, because ketamine is a safe medicine, but there are conditions that would exclude you from treatment.
And
so
what
there's
are
that. Those could be anything that's uncontrolled cardiac conditions, uncontrolled thyroid or metabolic conditions, acute psychosis, acute substance use, things that would destabilize the patient worse, right? And so but or liver issues, anything that would make the medicine not work as effectively or worsen that condition. And those are some clear indications, but there's subtle conditions too that we're also assessing, meaning therapeutic safety. Is this patient well resourced to do this work? Are they ready? Do they have support? Are they in a stable situation? Are they recognizing that this is a commitment and they are ready to do this work right now or later? And so making those assessments is also part of our intake process. So there's that medical intake, it's quite comprehensive. And then if therapy is needed, then there's a therapy intake. And then there's some preparation that's involved. And then there's a series of therapy sessions and medical sessions too, to clear and get blood work and make sure that there's nothing else happening in the body as well.
So I don't just get to come in, hand you $100, lay down on a mat and do ketamine.
Not at our center, but there are centers that are just doing ketamine treatments where you're in and out of treatment. And for me and for our understanding, and in psychedelic medicine, this is a key component that's discussed, that there's a lot of ethics around this process, that one has to be very mindful of the benefit and the possible outcome, because poor outcome or bad outcome, bad trips, not supported, not facilitated, can really do more harm. And I will mention that when there's acute grief in ketamine, we have a lot of discussion about that too, because sometimes I've had patients who have had somebody pass away very recently and they're grieving. And that's a normal emotional response, and we want to be able to support that. We don't want to numb that or take that away from somebody as well. So acute grief is reviewed, and there's an assessment of that as well. And then there's a lot of work on having the patient really do the preparation, the intention, and building into the intentionality of their treatment, because we find that that intention really activates that pathway in the neural system, right? As you start thinking about, what am I really doing this for? Why is this important to me? What's my real intention? What do I want to get out of this? Who am I? So all these questions, when you start really probing at that and really facilitating that preparation for that sense of discovery, we activate those pathways, right? Those pathways start priming the system. And so when when treatments do start, it tends to flow into those places, those neuronal circuits. And again, and psychedelics means mind manifesting. And it may be woo-woo or maybe like, but it's facilitating that opening of pathways and activating of places that the brain doesn't really get to because it's so encased in this trauma response. And so it allows for that access to the other parts of the brain, the sensory, the cortical, the other parts of the brain that is, to me, that's where the regeneration, that's where the reset tends to happen. And then there's a series of sessions, all kind of decided. We take a very personalized approach, and I tell patients that ketamine is a unique, ketamine, you are unique, and ketamine will have a unique effect on you. And it's very odd to say that as a physician, because we're trained to tell you, oh, well, penicillin works and it'll eradicate the antibiotics and it'll work the same way every time. And if it doesn't work the same way every time, well, either you're resistant or it's not working, but that's not true. And every medicine has its unique effect on that system, and the outcome will speak for itself. And we can't really generalize. No one is an average number. No one is if it didn't work for 20% of the population, or there's a placebo effect, and we really look at that effect and keep that unique aspect in mind, because there's an interaction that the medicine having on your mind, body, soul. And so there's that aspect of preparing for patients even as they're going through treatments and making those clinical assessments too. We continue to track, how they're doing through their treatments, and provide that therapy, that support, and that guidance, to other resources and really building in their functional health. And often I see patients when they start to feel better emotionally, they start thinking, well, what else can I do? I feel suddenly the motivation to go for a walk, or they start asking about their health. They start asking about, well, what can I do now? How can I eat better? Something that they would have not really even focused on or felt. And there's that interest in taking care of themselves and taking care of their family. And then there's that. So it's quite involved.
So they do it as an individual, or do they do it in groups, or how do you
Yeah,
decide?
we do it individually, and we also do group sessions as well. And then again, there's an assessment of acuity, right? How acute, how we have patients who come in with suicidal ideation, and there's also we have to be able to address and stabilize that. And there's a treatment approach for that as well. But there's usually it's individual sessions, but we do group sessions as well. And group ketamine treatments has its own process and own effect. And there's usually an assessment of, is this the patient for group or individual, also being made.
And so what do you see in a session where somebody, I mean, sometimes we're treating one thing and we discover that it's actually grief under there that's been
Yeah,
causing all of the symptoms. They come in talking about depression, but then you discover unprocessed grief or
yeah, you're
loss.
right. It is. I tell patients, take the learner's mindset, because you never know what's going to come up. It could be, um, that connected to that inner child that they weren't able to see or hear. And so we see anything and everything often. And there are things that come up, especially when we see patients who've had extensive trauma, and we take care of the veterans as well. So there's often layers and layers and layers of things that um, people have experienced as adults, right? I'm a pediatrician, and I see now adult patients and take care of adult patients. And I find that 95% of patients have had trauma as a child. And about 70-80% of them have had it experience before they were 5. So it's like all this stuff has been happening while they were children. And we often see that developmental arrest because of that effect that trauma may have had during that time. And then we see that chronicity of that condition, right? It becomes an ingrained, especially in adults. We also take care of adolescents and young adults and find that because the way the brain matures, there's a different response effect of ketamine as well, and or psychedelics. And there's a lot of science around looking at how ketamine can, or even psychedelics can enhance ways of thinking, expand ways of thinking, a way of optimizing. And I find that the younger the brain, the more diverse the response. So, and it's all, and everybody has, we do brain mapping and QEEGs now, so we can really look at patterning, a functional way of looking at the pattern of brain function, and really then um, seeing how that changes over time with treatment. And that's fascinating. So there's a lot of science and neuroscience that's now changing the way that we're looking at mental health. We're really looking at again, the brain is, and the depression is not just a black box of symptoms. It's really a lot more physiological, and it has an effect on your body just as much as it has on your mind and your spirit and your emotional health.
So, so the model of therapy that I do most often is called comprehensive resource model. It's a little bit like guided meditation on steroids. And
Yeah.
it's sometimes people say it's like ketamine without the ketamine. So you have these big awakenings. And one of the things that can happen if it turns out you have an unprocessed grief is, as someone is, processing childhood trauma, someone wanders in, like a grandma that they never grieved, or a dad that they never grieved, and they just can have an imaginal conversation, sort of imaginal attachment repair, and it's very powerful and very life-changing. So does stuff like that come up in ketamine sessions?
All the time. Patients often have, especially in the beginning of their sessions, when I've seen this, where patients will, somebody will show up early on in their treatments, and it will be usually somebody like you described, somebody that they were connected to as a child. It would be a friend, and they often say, "Well, I don't know why my ex-girlfriend showed up. I haven't seen her or talked to her in 20 years, but she was there in my experience." And I said, "Well, what happened?" "Oh, she just kind of held my hand," or and I said, "Well, they're your guide, they're your friend. They're that safe person." And it's a resourcing. It's a way of that the mind is resourcing itself with that past experience and that past connection, um, with that person who may or may not be in their
Yeah.
life right now. And I see this all
They're
the
sort of
time.
conjuring up somebody that
Yeah.
used to be a source of oxytocin comfort.
Yes, exactly. Exactly. And it's interesting how this happens in that psychedelic mindset. And ketamine is just a catalyst. What you're doing without medicine works just as well. And I say this to patients, well, but ketamine gets there faster. It's like fast track into, and I often have patients tell me, well, it feels like 500 sessions in one. What took, somebody a year, they can do in a couple of sessions if they're resourced,
Right.
if they have that, uh, um, those skills and that support and that experience as well.
Yeah. So, at the end of my videos, I always ask everyone, if everybody just ignored this entire video and took one thing away from this, so like 1 minute of wisdom, what's the one thing you would want people to carry out of this video that they could remember and take with them
In relationship to grief or anything.
in relationship to your
Mm.
work, your experience of grief, treating grief? What's the
Mm.
nugget that you would want people to take away from our time here together?
I would say to patients that you already know why you're here. You just need somebody to hold your hand or facilitate you and have a space to really trust that feeling that already exists.
That's great. Okay. So thank you so much for
Thank
sharing with
you.
us and taking the time to do this. I'm very grateful.
Thank you.
And hopefully for people that have been wondering about what it's like to have ketamine therapy, this will answer some of their questions and just help them understand that grief is one of the many things that
Yeah.
lends itself to what you do.
Yeah. And on our website, we actually have a lot of resources, and I really like patients to really educate themselves even before any type of treatment. And I find that the research, the science, that knowledge, that trust in the process is really vital. And that's another thing I would say to a patient, that you have to have trust. You have to have trust in this process, have to have trust in this yourself, and having that trust in who you're working with. And that's vital. Um, so that's another thing I would add to that.
Cool. Okay, that's awesome.
Thank you.
Okay, so I'm going to turn off the recording and thank you once
And thank
again
you.
for being with